Minutes to kick on. Okay, so welcome to our meeting 2 for the Georgia Occupational Regulation Review Council. Our first order of business is to approve the minutes from our last meeting. So just to give a quick recap of what we discussed, we heard from Senator Huffstetler about his bill, as well as Bill Button from the GAAA about anesthesiologist assistants and what role that they play in the healthcare system and the care that they provide. We heard that this bill would separate out anesthesiologist assistants from the physician assistant's license. They're currently combined under one. We also heard about how these licenses are structured in other states. And we heard from Daniel Dorsey, the executive director of the Composite Medical Board, and heard that there was no designation currently who's a PA and who's an AA under that license. So, you know, the meeting minutes were sent out to council members ahead of this meeting. Does anybody have any changes that they want the record to reflect? Okay, seeing none, we'll entertain a motion to approve those minutes, and we'll need a second.
Motion to approve.
Go ahead. Sorry, Chuck.
Representative Cooper, would you like to second?
Sure, I second that motion.
Okay, and we'll just take a verbal vote. All those in favor, please say aye.
Aye.
Aye. Any against? Aye. Okay, great. So our, second order of business is to have some follow-up discussion on the bill to answer any outstanding questions that council members may have thought of since our last meeting that some of our experts can answer, as well as the bill sponsor, Senator Huffstetler. So does anybody have any follow-up questions that they thought of since our first meeting? Okay, pretty simple. We will now move to public comment. If there's anyone on the call that would like to speak on the bill or provide their thoughts, please just send them a message in the chat and we'll add you to the list. So far, I have 2 people on signed up to speak. That's Jet Tony from the Georgia Society of Anesthesiologists and Richard Evans from the American Academy of Anesthesiologist Assistants. Jet, would you like to go first? I thought I saw him join.
Here. Jet, you're not hearing. Can't hear you.
He's talking, but
You're
still muted.
Yeah,
There you go.
So you're saying that I'm talking, but I'm not saying anything? Is that? Well, good afternoon. And thank you, Megan, for this opportunity to present. The Georgia Society of Anesthesiologists is comprised of more than 1,300 members, including more than 800 physician anesthesiologists and 350 certified anesthesiologist assistants. The mission of the GSA is twofold: to provide world-class continuing education for anesthesia providers and to advocate for public policy and regulation that assures the highest quality anesthesia and perioperative patient care. My name is Jet Tony. I serve as the Executive Secretary and lead lobbyist for the GSA, the latter position I've enjoyed since 1992. During this 30-year period, I have participated in dozens of public policy discussions regarding anesthesia and perioperative care at the state and federal levels. As the former executive director of the American Academy of Anesthesiologist Assistants, I am aware of what is occurring across the nation regarding the practice of certified anesthesiologist assistants and the state licensing platforms which regulate AA practice. As Georgia is the birthplace of the AA profession, it is ironic that a proposal for a complete and thorough Licensure Act specific to AAs has not occurred until Senator Chuck Hustetler's introduction of SB 643. The 50-year deficit of specificity is a testimony to the good work of the Georgia Composite Medical Board members and staff to consider AA applications, license AAs, and regulate AAs in practice within the broad framework of the General Physician's Assistant Licensure Act. With AA licensure acts on the books in more than a dozen states for many years now, and more licensure acts being adopted by state legislatures each year, it is Georgia's time to adopt licensure legislation that will become the most updated model for future AA licensure bills in other states. In Mr. Bill Bunton's testimony during your first hearing on SB 643, Mr. Bunton presented two primary reasons supporting the Review Council's approval and then legislative enactment of SB 643. First is transparency. The public needs and deserves to be aware that AAs are not PAs and vice versa. The patient should know that a professional specifically trained in anesthesia and perioperative medicine is providing care during, before, during, and post-operatively. Searches on the Georgia Composite Medical Board website for names of licensed AAs are published as PAs, not AAs. And this specificity is important for those patients and other healthcare providers who are looking to see who is providing care. The second reason is a standard of care consideration. A complete and thorough delineation of AA licensure will benefit patients and equip members and staff of the GCMB to license and regulate AAs to the specific scope of practice for AAs. Now, those are two excellent reasons for supporting the passage of SB 643, but there's something coming on the horizon. The GSA supports SB 643 for these two reasons previously mentioned, and then also because of what the legislature will likely face within the next few years. And that is an aggressive scope of practice and independent practice initiative by nurse practitioners and physicians' assistants who will ask the legislature to grant greater autonomy in where those personnel can provide care. When NPs and primary care PAs start asking the Georgia legislature to authorize practice with no or less physician supervision and oversight, the legislature will be put in a tough spot of having to distinguish between those non-physician providers who desire independent practice from those practitioners and PAs who are more comfortable remaining within the care team model of care that is prevalent, for instance, in anesthesia care. An AA-specific and separate licensure act will equip members of the General Assembly to more thoroughly understand the specific scope of care that each of the non-physician healthcare providers give to patients. So to reiterate, the Georgia Society of Anesthesiologists, which is primarily comprised of those physician anesthesiologists in practices where AAs are practicing and will practice in the future, supports passage of SB 643. It's time to end the 50-year deficit of AAs being licensed generally as PAs in this state, and for Georgia to join the other states that have specific licensure for anesthesiologist assistants. Thank you for the opportunity to testify, and to present the statement of support, and I'll be happy to answer any questions.
Thank you. Does anybody have any questions? Okay, well, thank you so much. We will now move on to Richard Evans with the American Academy of Anesthesiologist Assistants.
Yeah, thanks, Megan. Can you all hear me okay?
Yes.
Great. Yeah, thanks for the opportunity to visit with you all today. I'm the Director of State Affairs for what we call Quad A, the American Academy of Anesthesiologist Assistants, and we're the national organization representing the AA profession. There are about 3,200 certified anesthesiologist assistants that practice around the country. We have 21 jurisdictions where we practice either through licensure or delegatory authority. But as Jet mentioned, Georgia is the oldest state, and we've got the largest population of AAs of any of our states there in Georgia, with about 1,000 AAs that they call Georgia home. So every other state where we have licensure, the medical board is the agency that regulates AAs, with the exception of Kentucky. And we actually don't have anyone practicing in Kentucky because they require that an AA also have a license as a PA, which is kind of unnecessary. So every other state, though, it's through the medical board. So I do think it makes sense to separate out the AAs from the PA board, although I believe it's worked well. We definitely have a robust population there, but it makes sense to make that separation in the legislation and conform with what other states do. One of the other benefits, and Jed and Bill both mentioned this, is transparency and the ability to know specifically, who are AAs practicing in Georgia, and that doesn't allow us right now. The current model doesn't allow us to identify those. It's also, for me, I work with a lot of other states to try to get licensure legislation passed, and we always get asked by legislators about disciplinary actions in states, and they are very few and far between. But Georgia being the largest state, it would be nice for us to be able to cite that as a state where we have statistics and some data to show that we don't have complaints or disciplinary actions occurring. The second largest state is Florida, and I recently checked there, and since we've had licensure there, I think for about 18 years, there has been one disciplinary action that's been completed in Florida. So we suspect that in Georgia, it's going to be similar, where it's a very low number. But right now we can't track that. So I think that would be an additional benefit. And I would like to echo what Jet said. There is a move by providers to gain independent practice. AAs always practice under the direction of a physician anesthesiologist, and having a separate AA license, I think, does help in the debate about independent practice and keep us out of that fight. So I'm happy to answer any questions that you have about the AA profession. It is growing. We did add Utah as a licensed state this year. Pennsylvania was just added as a delegatory authority state. And next year we expect to have probably 15 states with licensing legislation filed. There's a lot of pressure with the workforce shortages for more anesthetists to be able to practice in these states. So it's definitely growing as a profession, and we have now 13 accredited programs around the country where we produce about 325 new AAs every year, and we've got 5 more programs that are seeking accreditation. So it's growing in the number of programs we have and the number of states where we practice. So I'm happy to answer any questions that you all may have.
I have just one question as more of a curiosity, but do you know what's driving the high number of anesthesiologist assistants in Georgia? Is it due to, the educational institutions that offer that degree and people just decide to stay in Georgia, or is there something else driving that?
Jet may be able to speak to this better, but I think that you're right. It's the fact that Emory had the first program, and students tend to stay where they get trained, because part of the AA program is a 2-year master's degree program and 11 30-day rotations in hospitals. And so I think that, you get your students there, they rotate primarily in in-state hospitals, and that's kind of the place where they are getting checked out by their employer to see whether or not they want to hire them. So I think they just stay there in the state. I'm from Texas, so I know y'all have great football there too. That may be another driving factor. But yeah, I think it's just because we have a great, very robust educational program there with Emory that's been in place for so long, and it's a good environment for the AAs to continue to stay in practice.
Go Dogs.
Ah, dog crazy.
Great, thank you so much. Is there anyone else who would like to provide any comment on the bill?
If I could step in and just say a couple of things, it's a little bit technical, but the 2-year program, 24 months, we're actually at 27 months at Emory. My class was the only class that was 24 months, I believe, and they decided it was a complete and miserable failure. And so they went back to the 27-month program. And the other thing, I don't think we've really explained in plain English how this works in Georgia, the Georgia model. The Georgia model is somebody like me or Bill or a CRNA. We're about 50-50 at my hospital is in the room, and they're being supervised by an anesthesiologist like Dr. Al that was in the Senate with me this year at St. Joseph's. So they can supervise up to 4 rooms at any one time. Obviously, when I'm doing open hearts, they're in there a little bit more helping. In other cases, they're not there very much. And so it's a wonderful ratio. And I think that model works really well because you actually get 1 1/4 people in the room. And when they need it, there's 2 people there. So I think it's a good model that extends out the anesthesiologist. Now the CRNAs at the big hospitals are under the same thing, but they do have the authority to work under the surgeon. And so in some of the smaller hospitals where maybe the surgery is not quite as complex, they will have just CRNAs there. And I'm not here to discuss that either way today. I'm just trying to make sure you guys probably don't really know how everything works. And I was trying to get in plain English and explain how the Georgia model works was the only thing.
That's always appreciated. Thank you. Okay, well, if there's no one else, we'll move into our next agenda item, which is the discussion of the draft report and findings. So, council members, you should have received a copy of the draft report, I believe, Monday. In that report, we've outlined the discussion that we've heard, some of the background research that we've conducted on this profession and this bill. And one of the draft findings I think has been reflected from meeting 1 and this meeting is under the need for a specialized license for anesthesiologist assistants, seeing that the qualifications in the scope of practice is different from your PAs, that maybe having it separated under a different license would be less confusing for the patient. And as of right now, that is kind of the only finding that we've really discussed, but I want to open it up for discussion to see if anyone else has any thoughts as to how this bill falls under our GORRC code. And again, I can summarize some of those criteria for us to evaluate bills under. One is whether or not the unregulated practice will harm or endanger the health and safety and welfare of citizens, whether or not it requires a specialized skill, which I just discussed, whether the citizens of the state may be effectively protected by other means, whether or not the overall cost effectiveness and economic impact would be positive for the citizens, and whether or not there are other means of regulation to protect the interest of the state. Does anyone else have any thoughts on this bill as it relates to those items?
I think one more item to add to that is just the standard of care, is maintaining the standard of care for the patients. Not just transparency, but being able to, like Richard and Jet both said, just to make sure that our scope of practice and our standards are maintained specifically for anesthesia and not as PAs in general.
Thank you.
Yeah, I think it's also important that you are able to track disciplinary action. I mean, I think that's a quality issue. I'm sure Mr. Evans is correct. I'm sure the numbers are very low, but if there is a problem, then it would be able to be recognized and evaluated. And it also, listen, if Georgia is the largest state with a number of AAs, and I presume it's because, like you alluded to, is that we have the initial program at Emory, and then South University, where I am here in Savannah, also has a program. And Georgia's an attractive place to be, from that perspective, as we all know. But the ability to say that AAs do not have an issue from a substance abuse standpoint, or they do have an issue, or there's a really small percentage, I think that goes to the quality of care, quality of our product that we're delivering here at Emory and at South, quality of the institutions in our state. And it goes to the core of what we do in healthcare is related to quality of care delivered to the patient. So I think that I think transparency is certainly very important. Don't get me wrong, but I think that really, when it comes to the reason that we're doing it, is more important than anything. And as Chuck has heard me say, and I'm sure Sharon and Jet and everybody has heard me say so many times, that when we're delivering quality care, we drive also the price of care. So the price goes down as the quality increases, and that would be my driving force behind this. Is certainly, I think transparency is important, but quality would be the most important thing to me.
Okay, thank you. So, with this being our second meeting, we'll incorporate some of these points into the next draft of the report. In meeting 3, we'll have a vote essentially to approve that report and to, approve the recommendation of the bill in whatever state we agree upon as a council. Is there anyone at this point who feels like this bill should not be recommended to pass as drafted? Just, this isn't a formal vote, just kind of seeing what the feelings of the council are. Okay. So, like I said, we'll incorporate some of these points into our next draft and send that draft out to council members again. Our next meeting will be on July 21st from 1 to 2 to take that formal vote on the draft report and to include our recommendation. And just some other housekeeping items. Our draft meeting minutes will be sent out to members after this meeting. Minutes from meeting 1 will be posted to our website now that they've been approved. And a recording will also be posted on our website of today's meeting for future reference if you want to go back and listen to something someone else had to say again. So with that, if there's no other items for discussion, we will go ahead and adjourn.
Thank you. Bye, everybody.
Thank you all for your time.
Thank you.
Thank you, Megan.
Bye.